Thank you very much, sir, for a very kind introduction at the outset. I must congratulate Bansi, Evergreen Bansi, and his entire team for conducting such a fantastic, scientific, and excellent conference. The topic given to me is sulfonylurea in type 2 diabetes. Should they stay? What is the opinion of the audience? Should they stay?
Yes. Last in Nasa.
Last in the hierarchy, but everybody says stay. See, today is a golden period for diabetics and diabetologists. All the molecules have gone off patent and they're quite cheap. Previously, in the early 2015 and all, we used to say, resource less you give sulfonylurea. I'll show you the slide also. But today, I think your DPP4 and your SGLT2 are cheaper than sulfonylurea. So we are not looking at cost. Now we are looking at the real evidence, what we need to do. So the question is, should they stay? My answer is yes. They definitely have a role and they have to stay. But the big question is, where should they stay? At what level? Do we start with the sulfonylurea or what? What is the present day scenario? This is an Indian 30-year-old who is expected to live up to 75 years. But if you have a diabetic at 30 years, he is going to lose 14.5 years of his life. So when you are going to treat your diabetic, this is what you have to keep in mind. That this patient, this young 30-year-old, is going to lose 14 to 15 years of his life. How can you prevent that? How can you give him a nice, healthy life much beyond 75? And what does this diabetic really die of? 80% will die of a heart problem or a macrovascular disease, stroke, peripheral vascular disease, myocardial infarction. 60% of all patients in dialysis with end-stage renal failure are diabetics. And today, NASH and fatty liver is becoming a widespread epidemic. We're just seeing the tip of the iceberg. It leads to cirrhosis and hepatocellular CA and can be very taxing. Today, we have these 9 therapeutic classes of oral hypoglycemic agents which are currently available, 7 oral, of which it's only the oral semaglutide which is very expensive. It's almost 10,000 bucks a month. All the others are within 10 rupees a tablet, most of them. The injectables are going to revolutionize the treatment of type 2 diabetes. Your GLP-1 analog and your co-agonists like tirzepatide, excellent weight loss, and lot of pleiotropic benefits, cardiovascular benefits, and renal benefits are coming in. And finally, the injectable insulin we have. This is Ralph DeFrance's ominous octet. You have 8 different pathophysiological mechanisms which will contribute to hyperglycemia. And you have different molecules which are going to be effective at different pathophysiological sites. So there is absolutely no way that a single drug is going to treat all of this. You have to start a combination therapy. And like my friend Anil Virmani said, you have to be aggressive from day one. Forget that step by step policy which we had. अरे lifestyle करो फिर metformin लो उससे नहीं हुआ तो फिर sulfonylurea लो. It is all bunk. That is a sure treatment waiting to fail. And you are going to change your treatment after you have failed. You start with a combination therapy right from day one. And if required, then you step down rather than step up. So combination therapy should address the basic pathophysiological targets of type 2 diabetes. And now I'm talking in context of the sulfonylurea and the other ones. When you look at treating type 2 diabetes optimally, you obviously need good glycemic control. That's your first thing. And this good glycemic control is primarily going to answer or be effective in reducing microvascular complication. By and large, the microvascular complications of retinopathy, nephropathy, neuropathy is glycemia driven and they start after the onset of diabetes. Whereas the macrovascular complication starts much before the onset of diabetes. As has been shown in the nurses' health study, that the risk for cardiovascular problems starts more than 15 years before the onset of diabetes. And this is because of the dysmetabolic syndrome, which is characterized by insulin resistance, which to my mind is the most important factor in type 2 diabetes, obesity, hyperinsulinemia, hypertension, dyslipidemia, atherosclerosis, and so on. So, when you talk of combination therapy, it should address the pathophysiological targets for type 2 diabetes. First, you want to achieve a good glycemic control. All your molecules which are anti diabetic will reduce blood glucose. And the most potent in that is your insulin and sulfonylurea. They can reduce HbA1c up to 2%, the sulfonylurea. So sulfonylureas are a very potent, time-tested molecule which is there. So when you talk of achieving good control, all your anti-diabetic drugs will give. You want to preserve the beta cell, which will give a durable glycemic response, because the apoptosis of the beta cell is what leads to the progression of type 2 diabetes. And in that, you have only a glitazone, which by mobilizing the toxic lipids out of the beta cells can preserve the beta cells. So when you talk of preserving the beta cell, you only have pioglitazone. There are some studies with GLP-1 which has shown to be, but those have been in mice, but that is there. So as far as preserving beta cell for all practical purposes, what we have is pioglitazone. You want to treat insulin resistance? This is insulin resistance, the clinical manifestation. And if you see the last clinical consequences, it leads to diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, NAFLD. You name the thing, and everything is driven by insulin resistance. And we Indians are ethnically an insulin resistant population. And we have central obesity, most of us. The Indian phenotype is classic, like shown in this picture. Central obesity, even I have one. Yeah. No, I have kept it only to show you all sometimes. So, this is the typical Indian. You see a Caucasian or an American obese guy, he's fat all over. But you see an Indian obese, he walks in with his stomach first and he follows behind. This is a typical insulin resistance. And is there any evidence that treating insulin resistance will help? Yes. The IRIS study was done in non-diabetic patients. I will not go into the details of it, but it was patients who had stroke, who were non-diabetic, were given pioglitazone to treat insulin resistance, and this was what they found in 5 years. That recurrent stroke reduced by 24%, myocardial infarction by 24%, and new onset by 52%. So, for the first time, we have a specific treatment aimed at treating insulin resistance, which has shown non questionable benefits in cerebrovascular and preventing cardiovascular and cerebrovascular stroke. But look at this. Professor Virmani was speaking about prevention of diabetes, treating pre-diabetes. This is treating pre-diabetes. In this study, there were 2,885 patients who were pre-diabetic. And when they were given pioglitazone for 5 years, look at this thing. Combined stroke and myocardial infarction reduced by 40%. Stroke alone by 33%. Acute coronary syndrome by 52%. And new onset of diabetes by 80%. So what Dr. Anil was saying was, you treat early and you treat aggressively and you treat rightly, you will give the benefit to your patient. This is just, I studied non-diabetic, pre-diabetics treated, this is the benefit. No GLP-1 gives this, no SGLT2 will give this kind of a result, which is seen here. So following this, the American Heart Association and Stroke Association talk of pioglitazone in patients with stroke. There is no sulfonylurea here. There is no role for sulfonylurea here. Talking about fatty liver, this is the ACE 2022 thing, that 90% of patients with type 2 diabetes have a fatty liver. 90%. And in fact, we have done a study in our clinic. This was the paper which was published, which showed that randomly we have done fibroscan for the patients. 75% of the patients who don't know they have fatty liver have already got fatty liver, and almost 28% already have existing fibrosis. So here again, we are looking at a silent epidemic. We don't know that it is there, but this should get incorporated in your treatment, and this is driven by insulin resistance. So these are all the randomized controlled trials which basically show the importance of pioglitazone, vitamin E, and liraglutide. These are all the guidelines which say use pioglitazone and GLP-1. Again, no sulfonylurea has any role in this. So where is the sulfonylurea going to come? ADA guideline says use pioglitazone or a GLP-1. Now you have the co-agonist, tirzepatide, and you have retatrutide, which is now in the final phase. It will come. And there the data has shown that in 48 weeks, using retatrutide, fat in the liver disappears 90%, 48 weeks. So that is the kind of things which we are seeing. And this is the EASD guideline, which looks at for fatty liver, resmetirom if there is fibrosis. But in type 2 diabetes, they are only talking of GLP-1 and coagonists like tirzepatide, SGLT2, metformin. And if there is obesity, GLP-1 and bariatric surgery. No sulfonylurea anywhere in the picture. And when you talk of this recent guidelines, these are all the ones which can be used, but these are the only ones which are cost effective and currently available in our setting. So when you talk of treating insulin resistance, you have GLP-1, tirzepatide, SGLT2 has been shown to have some role, but pioglitazone still is the main. Should not cause weight gain. There are only three molecules which will cause weight gain: the sulfonylurea, the glitazones, and insulin. And if you don't use them, what you have left is a metformin, DPP4, SGLT2, and a GLP-1. There will be no weight gain. But the GLP-1 and the co-agonist tirzepatide can give you good weight loss. SGLT2 can give you weight loss. Metformin and DPP4 are weight neutral. So when you talk of weight gain or weight loss, sulfonylurea will cause weight gain. So that again goes down. You want to have renoprotection. This is a paper just published last year, July, that semaglutide has been shown to have very beneficial effects on renal function. In fact, today morning I read an article that tirzepatide, the Surmount study has shown that in ad hoc analysis, excellent, I won't say excellent, but good improvement in urinary albumin creatinine ratio with the use of tirzepatide. SGLT2 is there to stay. Very good results with SGLT2. So when you talk of renoprotection, you have GLP-1 analog, and now you have the co-agonist also and SGLT2. Again, no sulfonylurea anywhere. So kyun wapre? Now we come to cardiovascular protection. SGLT2 has shown excellent benefits in cardiovascular protection and heart failure. Pioglitazone in all these studies have shown excellent benefit. This is a Robert Ryder and Ralph DiFranzo's comments. Pioglitazone inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, plenty of evidence of cardiovascular benefit. So when you talk of cardiovascular benefit, you have metformin, which had shown benefit in the UKPDS in the selective obese category. Pioglitazone, whole host of studies, SGLT2, GLP-1, liraglutide, semaglutide, and even the coag. Now the last is should not cause hypoglycemia, because if hypoglycemia was not there, there would be no need of diabetologist. बिंदास दे दो और सो जाओ. शुगर कम हो गया नहीं हो गया सोचेंगे बाद में, बट टेंशन नहीं है. Tension is only because of hypoglycemia. And when you talk of hypoglycemia, there are only two molecules which will cause hypoglycemia: sulfonylurea and insulin. So, to my mind, they should be the last ones to be used. Last ones. If you can't control with all the other drugs, फिर सोचो sulfonylurea और insulin के बारे में. So when you take, should not cause all except this. So sulfonylureas, this is the 2015 ADA guidelines which says if cost is a problem, minimizing cost, then you use sulfonylurea, glitazones, and metformin, triple drug combination, which is there in our country rampant. So sulfonylureas have been a cornerstone of treatment. There is absolutely no issue about it. Now, with increasing availability, we have all the other drugs which are quite cheap today, and in fact cheaper than sulfonylurea. So they should be the first ones to be used. And what do the guidelines recommend? Now, this is about, again, ACE guideline 2023 about treating pre-diabetes. Dr. Anil Virmani was saying we should treat pre-diabetes. Yes, lifestyle does not work. Let's be very clear. You look at all the DPP-4 studies, at the end of 5 years, you have 38% prevention of diabetes, some 50%. With metformin, also similar. The best results were seen with pioglitazone in tripod, bipod, now study, and even in this IRIS study, they said 80% reduction in new onset of diabetes. So basically, you need a drug treatment. And the best is if the patient is overweight, with the new GLP-1 and the co-agonist, good weight reduction, that can be a beautiful way of prevention of diabetes. And if that does not work, then what ACE guideline says, use metformin, pioglitazone, and acarbose. Metformin, pioglitazone, and acarbose, not sulfonylurea. This is the 2025 ADA guidelines, which is very comorbid centric. You look at ASCVD, GLP-1, SGLT2, and if that doesn't work, then there's pioglitazone to be added. Similar here, for heart failure, it is SGLT2. For CKD, again, SGLT2 and GLP-1, which is coming. And if you look at this side, the readability is very poor, unfortunately. For weight management, very high potency are your semaglutide and tirzepatide. Dulaglutide, liraglutide can be used. GLP-1 along with SGLT2 can be used, and so on. So basically, this is what has come. So what would be the best combination that you can think of? A GLP-1 or a co-agonist like tirzepatide with SGLT2 and pioglitazone will address most of the pathophysiological mechanisms. You don't need any sulfonylurea here. But if this is unable to control your sugar, then you can add a metformin or a sulfonylurea and finally an insulin. But a cost-effective combination is metformin, SGLT2, and pioglitazone, which will address most of the pathophysiological mechanisms. Then, if you need to add, you add first a DPP-4. If that doesn't work, you add a sulfonylurea and finally insulin. So, an ideal algorithm, this is Panikar's algorithm. You want to reduce peripheral insulin resistance, you have glitazones and metformin. You want to preserve the beta cells, you have glitazones. You want no hypoglycemia, so you don't have sulfonylurea and insulin. You want cardiorenal protection, you have metformin, GLP-1, SGLT2, the whole works. So this group of drugs is your first line. If that doesn't work, then you use a sulfonylurea. And among the sulfonylurea, what I would most prefer is a modified release glycoside, which has been shown in the advanced study to cause minimum hypoglycemia chances and minimum weight gain. If you only have a postprandial hyperglycemia, you could add an alpha glucosidase inhibitor. If all this doesn't work, you will give insulin. वो घंटी के साथ ही इंसुलिन आया है तो घंटे की बात है ये. So this is what the algorithm would be. Thank you very much. And thank you, sir. But I will tell you, still almost 70% of your patients will need a sulfonylurea. Let's come down to brass tacks. ये सब मैंने बोल दिया. But sulfonylurea is still and very much integral part of treatment of type 2 diabetes. A low dose sulfonylurea will work. Thank you.